Good morning, everyone. I welcome you all on the behalf of Sir Ganga Hospital and Delhi Liver Foundation to the third day of clinics in Hepato-Biliary disease 2025. To begin our first session, what is new in hepatology? I would request the moderators, Dr. Geeta Rani Ray, Dr. Sabyasachi Patnaik, Dr. Saroj Kant Sinha, Dr. Manish Paliwal, Dr. Abhishek Deepak, and the chairpersons, Dr. Rajneesh Gulati, Dr. Mahesh Gupta, Dr. Rajdeep Singh, Dr. Prasann Veer Singh, and Dr. Vasudha Goyal to please come on to the stage. And our first speaker is Dr. Ashok Chaudhary, and the topic is Kyoto Consensus in ACLF, implications for a practicing gastroenterologist.
Can we start now? Yes, sir. Good morning, everybody, and welcome to this conference. This is very important session we have now. What is new in hepatology? I have the pleasure to invite Dr. Ashok Chaudhary, who is a bright young hepatologist. He will be speaking on Kyoto Consensus in ACLF, implications for a practicing gastroenterologist. Dr. Ashok Chaudhary, the rise is yours. I think Ashok was outside. Can someone call Dr. Chaudhary, please? I saw him outside. Dr. Ashok Chaudhary is outside, no? His first talk is here. I just saw him a minute back in the outside the hall. So can someone call him or phone him? He's got first session and first talk.
It's not 9 o'clock, so he's not at work. It's 8:59 right now.
Oh, maybe.
1 minute more,
No, it's okay, no problem.
Hello.
Welcome, Ashok. He's on time all the time. Thank you, Ashok. You can start your talk, please.
My apology, I am here only. Sorry. Thanks at the outset, whole Ganga team and particularly Ashish sir for, I can say selectively deciding this topic, which is not into, I think, this session. The Kyoto Consensus, I think you can see here, it is a huge list, close to 200 authors, and hopefully I got criticism of having 107 pages of the consensus. People are fear of reviewing it, but luckily we will go with this. And so in just brief, as you know, the liver injury to a patient of cirrhosis or advanced fibrosis, that is F3, F4. So these are the acute insult where the disease present can be ACLF or a decompensation present with acute decompensation, non-acute decompensation, and over the time they may develop regression or the recompensation. And in this process they may have faced challenge of SCC, significant portal hypertension, risk of further decompensation, and entity of ACLF again. And when these people is being followed up, some progress, some regress, some require transplant, some lands to have the death. So this slide shows that the whole liver disease comes into a single spectrum, and I think here we are able to take the opinion from all the groups of ASL and ASLD, so that uniformly you can define a person who is having advanced fibrosis or cirrhosis, how they respond to an acute insult or the precipitant, whether it is decompensated, compensated cirrhosis. So if this is the way a response is happening, so these are the definitions which has been existing and which has been adopted. I think acute decompensation is recent worsening, whereas non-acute is the most of the patients we see who remains decompensated throughout, requiring tapping, minimal of the treatments, and they have a less mortality but they are decompensated, no acute. Those having some recent worsening, and those already decompensated is called as the end stage liver disease, which is now ESL and ASLD don't want to use the end stage word. Hence those are having decompensated, they are getting worsening because of the disease course is being progressed over the time. And ACLF is thought of to have a special pristine entity where the liver failure should be the main, in addition to the other complications should be there, so that you can able to know where the liver is main and where is the extrahepatic are the main problems. So as we saw, this is the total response. If you think of the matter of facts is the hepatic reserve. You can see very interestingly, this is what I have shown. This is the hepatic reserve and it's the total liver synthetic function. In ACLF, if it comes first time what is called as the apostle, there is a good chance of hepatic reserve is there. So I can see, you can see around 50% may response with therapy, particularly alcohol or autoimmune, they respond good way. Then as there is a reversal of ACLF, then become recompensation, or some cases particularly autoimmune they get regression or reversal of the cirrhosis, the hepatic reserve comes back. Whereas if it's acute decompensation, there is hepatic reserve is already low, and when they progress to further the non-acute decompensation, gradually the reserve is coming down. So when the reserve is low, they have a prone for having poor outcome, and there is a window of concept of having ACLF again. That means this term is taken by the PGI team. They are doing a multi-center trial on this. Thus, those who are recovered like alcoholic ACLF, if they are developing same, whether we should tell them as the acute decompensation or ACLF again. So this is a term which is needs to be validated. However, what I have discussed in this slide, this hepatic reserve is a understandable hypothetical entity. We have not calculated what is the hepatic reserve. So that is need further area, but obviously it is the clinical practice. As you understand, we think this is the concept of hepatic reserve. So when this is happening, thus reserve liver is low, they get an acute insult, and how they get it problematics, and which has been defined by the different sources till date. We are coming not yet to the consensus, I am telling just what is existing now. So apostle, the Japanese, the Chinese, ASLD also, and the Mexican team, they have defined this as the liver failure should be at the core. The bilirubin is 5, now this cleared group has come as bilirubin 7.5, but whatever may be, there should be a liver failure that is bilirubin and INR, and along with other complications are there, may or may not be. And if you think of that, they develop extrahepatic organ failures like cliff, it is there, but it is little bit maybe advanced, because if person is having liver disease, if a organ damage is there, the collateral damage happens when damage is more severe. So that's why the collateral damage is either simultaneous if the injury is more, or they develop a subsequent injury that is progressive. Then they develop complications like NAXL, so that any person who having more than 2 extrahepatic organ failures. So that means they are having multiple organs is already affected with the liver being at the core. So that shows more severity of the conditions. That means if you think this as the only liver to start, then it is maybe little bit early. With complications maybe late, but with multiple complications likely to be the very late. So this is what everyone is understanding, but only thing that these definitions are not able to sit across a chair, how to go for this spectrum. Then important one we have highlighted is a recompensation. I think recompensation is a good entity which is coming up now. We are seeing in a clinical practice, if a alcoholic, female, young, low BMI, non-diabetic, low MELD, and they in a period of similarly Hep C groups, if hepatitis B, or those having variable etiology but having a good reserve function, they may over the time can develop a recompensation. Recompensation is that they develop, I think everyone know criteria, that after the cause has been improved, portal hypertension not requiring medications, disease remaining malignancy, and they have no requirement to therapies. So this is what we strongly suggest, that ACLF group when liver is at the core, when acute is there, definitely recompensation should be one of the part. So after discussing the background, how this definition should go, that we have already discussed. This is the liver failure is taken in most of the societies, extrahepatic is in half of the groups, both are there in few, hepatic, time onset, and high mortality is in also in majority. So if this group C, there is few are in similar, few are the not having merge of this. So with this, so now after this Kyoto Consensus, we thought of defining this as acute hepatic insult, CLD with or without cirrhosis, Acute hepatic insult. Now the apostle has adjusted few things like upper GI bleed, post surgery, post test, which was not there till 2019, and background disease is obviously CLD is no problem. And then the extrahepatic available is not a no, it should be simultaneous or subsequent, it should not precede. Suppose a person has a AKI, bilirubin is coming later, it should be one of the complication progression rather than it should be ACLF. That means liver is there and then extrahepatic abnormality developing simultaneously or subsequently. And obviously there should be a score of reversibility because of a hepatic reserve is better in case of ACLF where the liver is at the core. If this, so the constitution has taken that it's
The study suggested that 7 to 10% necessary for improvement of histology, decrease the 7%, 90% decrease in NAFLD score, and 10%, 90% decrease in steatohepatitis. Fibrosis improvement requires more than 10%, and the most of worsening of fibrosis was seen in those patients with less than 5% of weight loss. So, stepwise plan for lifestyle modification, assess the diet and exercise, plan the diet and exercise, identification of barriers, behavior intervention, and follow-up and management. That should be done in all these patients. How does weight loss help in improving NASH? Reduces adipose tissue stress and improves insulin sensitivity. Now, diet, what is the role of diet? And I think diet is most important, and the most acclaimed and a diet is a Mediterranean diet. Then you have a keto diet, time restricted eating like intermittent fasting or alternate day, and the DASH diet. And we will see what is the evidence of all these. The Mediterranean diet has been tried in various trials, and this is one of the meta-analyses which I have taken, where 9 trials have shown, all the trials have shown benefit of Mediterranean diet. There is no histological data, but majority of the diet has seen improvement in liver fat, liver enzymes, and triglycerides. Now, what is a Mediterranean diet? You have olive oil as the base, fruits and vegetables, fish, whole grain legumes and pulses, nuts and seeds, and the red meat, poultry and dairy should be minimized. So mainly your food should be mainly fruits, vegetables and whole grains, legumes. The other type of diet, which is a keto diet, where you have a high fat, high protein diet with decreased carbohydrates. So it improves the insulin sensitivity, decreased lipogenesis, decreased fat and fibrosis. Evidence of this diet is limited. The other diet is a DASH diet, which is mainly done for hypertension, dietary approaches that the observation studies have shown benefit, but no strong data to suggest it. Time restricted eating or the intermittent fasting reduces BMI, reduces fatty liver, reduces enzymes and oxidative stress. This is one of the studies which has compared alternate day fasting on body weight versus intermittent fasting, and the study was a randomized controlled trial. Both the diets are well tolerated, weight loss of 5%, decreased fat mass, improved triglyceride, no change in LSM because this is a short trial of 12 weeks, not much difference between alternate day fasting versus time restricted fasting. Role of coffee. Consumption of coffee independent of caffeine may be beneficial. It was said that 3 or more cups per day are beneficial, and probably it acts on the ATP of stellate cells, blocking the multiplication, and then there is a concept of chlorogenic acid And the benefits of coffee are in the form of reduction of NAFLD and reduction of fibrosis in some of these studies. Alcohol. There has been controversial reports of alcohol and NAFLD. This was one of the reports in 2015 by Arun Sanyal group, who said that 2012 that the alcohol is better for NAFLD with the odds ratio of 0.55. However, the another cohort study which followed up in the Korea, alcohol use of individuals in patients with non-alcoholic fatty liver disease, there you have 352,000 participants, out of which 72 were with NAFLD, and the final analysis was in 58,000 people. And the observation of this study was that even moderate alcohol consumption, that means around 20 to 30 grams of alcohol, is also associated with more odds for. So moderate alcohol increases risk of fibrosis as decided by FIB-4 and NAFLD score. Role of sleep, short sleep and the daytime napping is associated with increased NAFLD, and this has been shown in this, that's the odds, to go back. Short sleep is associated in this graph with higher incidence of NAFLD. Smoking has to be ceased, and there is a paper in the Science where the steatosis reduced, insulin resistance improved, and it also reduces fibrosis. And this is a meta-analysis which shows that the odds ratio for smoker is 1.14. Exercise is the second most important, and the 1 mate is calculated as resting oxygen consumption of 3.5 ml per kg per, and the WHO recommends about 1,500 to 1,000 mates per week. Exercise improves insulin sensitivity, decrease lipolysis, increase glucose uptake, decrease hepatic steatosis, and triglyceride. So, does aerobic exercise reduce NASH and liver fibrosis? This is the systematic review where it has been shown that comparing the M.I.C.E, that is a moderate intensity continuous exercise versus high intensity intermittent exercise, not much of a difference, except that there is both are important. So aerobic training is foundational, 3 to 5 times in a week with about 150 to 2 minutes of walk. Examples are brisk walking, cycling, swimming. Resistant training, it should be adjunct to aerobic 2 to 3 times in a week, like weightlifting, not on consecutive days. It helps in preserving the mass. This is the new concept of exercise snacks, that is in between the sedentary periods for a period of 1 to 5 minutes, you climb the stairs, have push-ups, calf raises or high knee taps. Special population, lean MAFLD, I'm not going to discuss but would tell you that smaller weight loss of 3 to 5% is sufficient in lean MASLD. Cirrhosis, obesity with sarcopenia, protein intake has to be high. Compensated, you can use aerobic and resistant exercises, but it should be supervised. There is now role of digital health. You have parameters, the appliances like Fitbit, couple of slides more only, running apps, Apple Health and Healthify Me to calculate calories. The limitations of NAFLD is poor adherence, difficulty in achieving significant weight loss, Response is variable in individual patients. No long-term data. Majority of the times it is 12 to 52 weeks. So what is the take home? Limit sitting for less than 8 hours a day. Break up prolonged periods by intermittent activity. 150 to 240 minutes of aerobic exercise. 2 sittings of at least resistant exercise. 1000 minutes per week. Daily step count of 8,000 to 10,000. Sleep adequate, 8 hours. Healthy diet, hypocaloric diet, 500 to 1000. Mediterranean diet, the improving quality should be healthy diet. 3 cups of coffee. Avoid smoking and alcohol. Thank you.
Hello. Thank you, sir. Our next speaker is Dr. Ajay K. Jain. Sir, your topic is oral GLP-1 agonist future perspectives.
Thank you, chairpersons. Good morning, ladies and gentlemen. Congratulations to Dr. Anil Arora, Dr. Ashish, and Dr. Praveen and entire Gangaram team for organizing this fabulous meeting over the last many, many years. The task given to me is oral GLP-1 agonist, current and future perspectives. So before we go to this topic, we need to understand the history of oral GLP-1 receptors. So Professor Alfred and Professor Martin for the first time discovered the role of G proteins in the cellular signal transduction and was awarded a Nobel Prize for this discovery in 1994. Another 18 years later, Dr. Brian Korbila and Professor Robert were given a Nobel Prize for elucidating the structure and function of G protein coupled receptors, which is the key for the development of many, many drugs in due course of time. And this is the G protein coupled receptors structure, and because of the structure, it has multiple names. And these are the evolutionarily related proteins that are present as cell surface receptors. And they are the largest protein family which is encoded by the human genome, and they are all activated by agonists. So these proteins are involved in a wide array of physiological processes and responses, and they have been implicated in a large number of diseases due to their involvement in signaling pathways. And the diseases where these receptors have been implicated are Alzheimer's disease, diabetes, obesity, MASLD, cardiovascular diseases, inflammatory diseases, cancers, and many more. So this is how it works. The G protein coupled receptor is activated by an external signal in the form of a lesion or other signal mediator. This creates a conformational change in the receptor, causing the activation of G protein. And further, this G protein effect is dependent what kind of G protein is activated within the cells, and these are subsequently inactivated by RGS proteins. So the GLP-1 receptor is one of the family of this particular receptor. And upon binding of the GLP-1, this GLP-1 receptor gets activated, liberates downstream G proteins, which leads to cellular responses across many systems of the body. GLP-1 receptor agonists, which is now the drugs, mimic the action of this endogenous GLP-1, activating the GLP-1 receptor. And GLP-1 receptors agonists are synthetic protein preparations that have the partial or complete amino acid sequence, which is almost homologous to the GLP-1 found in the body. But as against the GLP-1 natural, which is degraded within the blood within a minute, GLP-1 receptor agonists are not easily degraded. They have longer half-life, and they have a stronger biological activity. Based on this, this was first used in the treatment of type 2 diabetes and works by mimicking the action of naturally occurring hormone, that is GLP-1, which is released by the intestine in response to the food intake. GLP-1 receptor agonists activate GLP-1 receptor signaling in pancreatic beta cells and in several other tissues and cell types to improve the glycemic control by enhancing glucose-stimulated insulin secretion. It also leads to decrease in glucagon level. It delays the gastric transit. Based on these GLP-1 receptor agonists were considered as the new hope in the management of diabetes, obesity, and MASLD in 21st century. What about GLP-1 receptor agonist and obesity? It works by numerous mechanisms that contribute to weight loss, and one of the most well-known mechanisms is gut-brain axis. Within this axis, GLP-1 agonists function by acting on both gut and brain. It acts on the central nervous system to reduce appetite, decrease hunger, and increase satiety. It slows the rate at which the food leaves the stomach, leading to prolonged feeling of fullness. The newer concept is an interaction of leptin with GLP-1. It is governed by the intracellular signaling pathways, including those involving phosphorylated state 3 and PTB1B. In recent years, the development of dual and triple agonists related to GLP-1 has been vigorously pursued. These multi-agonists simultaneously regulate multiple key metabolic pathways to achieve more effective control over blood sugar, body weight, and overall metabolic health. For example, the popular dual agonist is tirzepatide, which is also known as Mounjaro. It activates two receptors, GLP-1 and GIPR. By activating its receptor, it increases insulin secretion, reduces glucagon secretion, thereby lower the blood sugar levels. But it also helps in delaying the gastric emptying, suppress the appetite, and aid in the weight management. Triple agonist is another concept. That means they are targeting three different receptors, GLP-1R, GIPR, and GCGR. These receptors independently but complementarily have the role in the treatment of diabetes and obesity. Because of its effect on insulin release after meals, these drugs help to improve glucose utilization. By activation of the insulin-like growth factors, they can enhance the insulin sensitivity and improve the glucose absorption and utilization by cells. What about NAFLD or NASH? Other than exercise and diet, which is a very difficult proposition for all of us Indian, there is a drug which regulates the appetite, insulin secretion, lipid metabolism, and they have a potential benefit in the treatment of MASH. In the pancreas, they stimulate the secretion of insulin and inhibit the secretion of glucagon. In the brain, they reduce appetite and improve the satiety, and in the GI tract, they lower the synthesis and secretion of triglycerides. What about cardiovascular system, these are the future perspective. It has been shown that liraglutide and semaglutide exhibit pronounced cardiovascular protective effects. In the cardiovascular system, GLP-1 can reduce cardiac ischemia, reperfusion injury through the activation of specific signaling pathways such as PI3K and AKT pathways. It has also been found to significantly reduce the risk of heart failure, atherosclerosis, hypertension, highlighting their broad therapeutic potential in cardiovascular diseases. What about obstructive sleep apnea? GLP-1 receptor agonists improve the obstructive sleep apnea symptom by reducing the fat deposition around the upper airway, decreasing the systemic inflammation, and offering an integrated approach targeting the root cause that is obesity in obstructive sleep apnea. Additionally, they provide benefits for other obesity-related comorbidities in this particular set of patients, like hypertension, cardiovascular disease, which are commonly associated. The future integration of GLP-1 receptor antagonist in obstructive sleep apnea treatment will mark a paradigm shift toward the comprehensive management of these patients. What about arthritis? It has been found that GLP-1 receptors are present in the musculoskeletal system, and they have a great potential in treatment of many diseases because they are being found in articular chondrocytes. They suppress the release of cytokines like tumor necrosis factor, interleukin 6, interleukin 8 into the synovial fluid, reducing the inflammation within the joints, and thereby helping in osteoarthritis and rheumatoid arthritis. Similarly, in neuromuscular diseases, they have been found that these receptors are expressed in the inflamed muscle fibers, and therefore by agonist, they can reduce the inflammation. It has been found that they have a potential to slow the disease progression in Alzheimer's disease and Parkinson's disease. So these are very important drug targets. So GLP-1 receptor agonists are important drug targets. At this point of time, 34% of all FDA-approved drugs are from this GPCR member family. Of 826 human GPCRs, approximately 350 are regarded as druggable, and 165 of them are validated drug targets. In year 2012, 2 of the top 10 global best-selling drugs were targeting G-protein coupled receptors. So ladies and gentlemen, to carry home, GLP-1 drugs demonstrate immense potential in the medical field, with future research expected to expand their therapeutic applications. Primarily recognized for their role in diabetes, they have demonstrated significant benefit in cardiovascular health, skeletal muscle-related disease, obesity management, and neurodegenerative conditions. Researchers are developing more efficient formulation, such as long-acting and oral versions, to improve patient compliance and outcome. With increasing clinical evidence, these drugs are set to become essential for many complex diseases for the significant health benefit, addressing the unmet needs, improving the patient quality of life, and solidifying their role for future medical advances. And therefore, the future of GLP-1 receptor therapy is very promising. Thank you very much for your patient hearing.
Thank you, Ajay. Very nice talk. I think there are no more talks. Let's open the subject for discussion. Ajay, what is the various dose of oral GPA available? Like difference between 3, 7, 14, and have the higher dose been used in MSLD?
See, the problem is that we do not have the long-term data about their safety and the side effects. And one of the most important things which have been observed is the gallbladder diseases, pancreatitis, and pancreatic cancers, other than the GI side effects. So at this point of time, we do not have, but the doses in diabetes are very well established nowadays. So when you give subcutaneously for 7 days, and oral drugs are now available. So the most important thing is that you have to individualize the doses in various diseases.
For oral semaglutide, what is the effective dose?
I don't treat diabetes, but if anybody can help me in that.
There is only one preparation available as oral semaglutide. This is a preparation called Rybelsus. Conventionally, you start in a dose of 3 milligram, and over a period of 4 weeks, as you try to get adopted to the drug, you switch on to 7 and 14 milligram. So whatever literature is available till date is available at a dose of 14 milligram. But there is a new trial called Oasis trial. This is a product from a company called Novo Nordisk. They are coming up with a new formulation called Oasis, which has a 50 milligram. And it is believed that this 50 milligram of oral tablet called Rybelsus, named as Oasis, will have the same efficacy as 2.5 milligram of semaglutide, which is presented as Ozempic or Wegovy. So 2.4 versus 50. But as of now, we have been whatever is available with us today is 14 milligram. Start with 3, 7, and 14. In fact, as very rightly said, this drug was developed for management of hepatitis, for management of diabetes. It was incidentally picked up that these patients started having improvement in their liver fibrosis, in liver function test, and fibroscan improvement. That is how it was extrapolated to utility in patients with MASLD. So as of now, the future is that nobody wants to have a prick. So with better drug delivery system, it's possible that you will have equipotent dose of orally available GLP-1 agonist, which might replace these injections like Wegovy and Ozempic.
My question is to Dr. Rakesh Agarwal. It's clear that presently we do not need hepatitis E vaccine because the prevalent incidence has come down. So what is the reason for this? Have we developed antibodies due to previous infections, or our environment has become
Clearly
better?
a change in environment, better fecal disposal, because the only source is human feces, and in the last few years our country has done well on that. Antibodies, if they were to develop, then it would have happened much earlier. So we are basically just seeing improvement in sanitation.
Dr. Rakesh, the hepatitis A is increasing, but
Yes.
hepatitis
Yes.
A is increasing.
Yes.
So
Two reasons.
Same hygiene.
Basically, in hepatitis A, it is well known that improving hygiene will initially lead to increase in disease. There are three phenomena that happen with hepatitis A infection. First of all, we get infection with poor sanitation. Secondly, once we get infected, we develop immunity for life. Third, if infection occurs at early age, it is asymptomatic. When it occurs at an older age, then it causes severe disease. So, till about 15 years ago, everybody used to be exposed as a child. They would get infection as a child, no symptoms, and they would be immune for life. Now, with improving sanitation, we are not getting exposed as children. We grow into adolescence, and not having been exposed, we are not immune, and when infection occurs at that age, then severe disease occurs. That's the reason. That's
Both things that you get nowadays, the test when done, A and E are coming positive both. Many a times.
Please remember, I don't know what test your lab is using. The tests are very finicky. The test that seems to do well is the one-thigh test, which is good for IgM. And secondly, so the experience around the country is that hepatitis E has become much, much less. So
That's true, sir. That's true. What I meant to say is, doing an IgM, we are getting nowadays, if we send both for A and
you need
they
to
come
check.
positive both.
It's very difficult to say that both viruses are causing infection at the same time. Thank you.
Rakesh, do we have a data that other diseases because of the sanitation are decreasing, or is it possible that virus hepatitis E has become mutated and is less potent now?
Unfortunately, viral mutations don't happen so quickly the way we
It
think.
may have been less potent now. Rest other infections are not coming down.
Hepatitis
Typhoid,
A,
acute gastroenteritis.
hepatitis A change in epidemiology is a very similar phenomenon. The second thing is, we must remember that hepatitis E needs a large inoculum. Small number of virions do not cause disease, and those large inocula have changed with the change in sanitation. Hepatitis A, it's in India that we think that it is a waterborne disease or foodborne disease, a waterborne disease. Hepatitis A, the most efficient method of transmission is person to person.
A
By
question
close
to
contact.
Ajay, can I ask a question? Ajay, are all GLP-1 agonists the same? I mean, can you extrapolate the same data with sema or with tirzepatide or liraglutide? And when do you choose one over the other?
No, because they work at the different cell receptors. So if one is working on the muscle GLP-1 receptor, it will have a different action as compared
Let
to
me
the
put it some. You want to use it for obesity, diabetes, metabolic. Would
They are
you
the
prefer
same.
one or the other, or you could choose anyone?
So the choosing one or the other is based on their side effect rather than their effect. Almost all of them. So the 7 or 8 which have been developed over a period of time, they have a different half-life, they have a different side effect profile, and they have a different dosing schedule. And therefore, the preference is based on theirs, not based on their put action. Action is same and availability,
Dr.
obviously.
Thank
Dr.
you. I
Ajay.
think we have to stop here. Because the organizers said we have to stop because we have surpassed the time limit. So sorry for doctor's question from the floor. You can interact with the speakers at the tea time. And thank you, chairpersons and the moderators and all the speakers. Thank you very much.
Thank you, sir. For our next session on clinical pulse in day-to-day endoscopy, The moderators are Dr. Dinesh Garg, Dr. Abhishek Gupta, Dr. Shraddha Minocha, and Dr. Shahbaz Faridi. And the chairpersons are Dr. Kunal Das, Dr. Pankaj Dikshit, Dr. Jagdeep Singh, Dr. Ashok Goyal, and Dr. Jignesh B. Patel. Please come onto the stage. And the first talk of this session is Management of Colonic Inertia, and the speaker is Dr. Mukesh Sharma Podal.
Good morning. So at the outset, I'd like to thank the organizers for inviting me all the way from Kathmandu. So the topic given to me today is the management of colonic inertia. And imagine my surprise when I searched it in PubMed. So in last 10 years, there have been only 44 publications on this topic, and some of those are on cats. So let's learn together what the colonic inertia is. So basically, patients with colonic inertia will present with constipation. So constipation, as we know, is divided into two types, organic and functional. And functional is again further subdivided into three types. And depending on where you do the study, the incidence of these subtypes are different. So colonic inertia is basically a severe slow transit constipation. And as shown in the slide on the left hand side, you can see there is some overlap between patients with slow transit constipation and defecatory disorders that we have to keep in mind. So these patients should fulfill the criteria for functional constipation as defined by Rome 4, and these criteria should be for last 3 months with symptom onset at least 6 months prior to the diagnosis. So this is the criteria for the colonic inertia. It is not a standard criteria. This has been taken from one study. So patients will present with severe constipation and they will have delayed colonic transit as seen by the transit studies, the radiopaque markers as well as the scintigraphy. There should be no evidence of evacuation disorder that you can do by anorectal manometry as well as MRI difficography. And there should be absent or almost absent colonic motility, including propagated activity and response to meals. And there is no response to endoluminal pharmacological stimulation as well as to the injectable neostigmine. So these are the criteria for colonic inertia that one has to fulfill. So there are some risk factors that have been shown in some studies. So patients who are of higher age, females, some patients with medical issues, and patients with taking some drugs or sedentary lifestyle are at higher risk of this disease. The symptoms of colonic inertia, so as shown previously, the patients should have constipation. So we should inquire about the type of constipation that they have, the number of drugs that they have been taking, and the amount of drugs that they have been taking, or any manual maneuvers that they have been doing to relieve themselves of constipation. Since the colon is redundant, there is a lack of urge to defecate that the patient will tell you in his history, and these symptoms may be persistent for years without being diagnosed. So the diagnostic modality obviously is a proper history taking, as I have said, and then you should do some investigations that are available. So there is an Indian consensus that has been published, which has shown that if a patient has type 1 to 3 Bristol stool scale, then most likely they have delayed transit constipation. And this colonic transit study, the radiopaque markers, this is the protocol that we follow in our country also, the Ghosal's protocol. And the total 10 capsules with 60 markers are given, and X-rays are taken at 36 hours and 60 hours. This is a representative X-ray of a delayed colonic transit. So as you can see, 54 out of 60 markers are still present in the colon at the end of 60 hours. So this is suggestive of slow colonic transit. Showing you the large bowel scintigraphy for colon transit time. Now scintigraphy is done by patients taking the radio labeled water, and then imaging is done by a gamma camera as shown. And the colon is divided into 6 segments. The stool is given number 0.7, and the colon is given, colonic segments are given numbers based on the right towards the left side. So the right side is given 1, and then progressively 2, 3, 4. Each dot that is imaged by the gamma camera is given a point of 0.01. So you multiply that with the number of dots that you have counted in that segment with the points that have been assigned to the colon. See if, and the sum of which is called the geometric center. If the patient has a low geometric center, it means that most of the stool is on the right side of the colon, that is the patient has a slow transit constipation. So this is one of the images, so that of the scintigraphy. As you can see, patients with colonic inertia have a geometric center of less than 4.1 at 48 hours as well as at 72 hours. Now, colonic manometry is something that is being done in research as well as in some centers. So, as shown in this image, the colonic manometry catheter is inserted through the anal canal. It can be inserted through the oral route as well. And here the barostat balloon has been attached to the tip of the catheter. So, the barostat balloon is inflated and it touches the colonic wall. So, normally when a patient takes meal, there is contraction of the colonic wall, so that the balloon volume is reduced. The wall presses on the balloon and the balloon volume is reduced. This is the normal phenomenon as is shown in the upper part of the graph of the figure. But in the lower part where the patient has colonic inertia, the colon doesn't contract, so the balloon volume doesn't reduce. This reduction is also absent even after giving pneumostick vein. Thus, the diagnosis is established. So, manometry is useful for finding the phasic activity of the colon as well as the propagated contractions of the colon. Now, you should do anorectal manometry and MRI difficography because we want to rule out defecative disorders before going to a surgical option for this type of patients. So, on histology, if you take a biopsy, you can see some lipofuscin deposition on the lamina propria. This is basically due to the increased use of laxatives by these patients. And there is loss of interstitial cells of Cajal that can be seen. These cells are basically presumed to be the pacemaker cells and are residing in the smooth muscle fibers. As is shown in the figure which is labeled as control, shown by the red arrow, these are branch cells and they are c-KIT positive. But in patients with colonic inertia, you will find that there is absence of such cells. So, pharmacological treatments for chronic idiopathic constipation as is shown in this slide. So, you can do lifestyle modification or give dietary fibers or give laxatives, but by definition none of these will work in patients with colonic inertia because the colon is redundant. So, other form of treatments have been tried, one of which is the colonic pacing. As we know, there are 4 pacemaker sites on the colon: the sickle pole, the colocolonic junction, the mid-transverse colon and the colosigmoid junction. So, researchers have investigated and they have provided electrical activity to these pacemaker cells by insertion of the electrodes. And they have shown that in healthy volunteers, these electrical activity are present. But in patients with colonic inertia, no electrical activity is seen. In the figure, if you see the lines labeled as A, then there is no electrical activity. But if you insert the electrodes, and then you can see some phasic activity as well as some action potentials. So there might be some role of colonic pacing. Again, this has been studied in a few patients, like 9 patients they have done of colonic inertia. They have tried to see if colonic pacing works, and they showed that 6 out of 9 patients had pacing-induced rectal evacuation, and 3 of those had sustained rectal evacuation despite removing the electrical pacing. Now, the definitive therapy for colonic inertia is surgery. So, total abdominal colectomy with ileorectal anastomosis is the one surgery that is shown to have better outcomes. And results after colectomy is that at the end of 12 months, patient will be passing 3 to 4 stools per day. 81% of the patients feel that they are satisfied with the surgery. The surgery is actually with very low mortality, less than 1%, but some may have recurrent constipation. Again, these patients, because they have not been evaluated for rectal evacuative disorders, some patients may have generalized dysmotility of the entire bowel, so not only of the colon but of the upper GI tract as well. So that also needs to be accounted for before posting the patient for surgery. So these are the guidelines that have been published by the AGA. So in patients who have normal or slow transit constipation, one should try laxatives first. If there is no improvement, then modify regimen. Newer regimens agents can be tried, and repeat colonic transit tests can be done on medications as well. So if that is delayed, then consider gastric emptying, because we have to see if the patient has generalized dysmotility. So if that is normal, then only consider colonic manometry, which is not easy to do. And if colonic manometry is abnormal, then consider subtotal colectomy plus ileorectal anastomosis for these patients. Thank you for your patience hearing.
Thank you, sir.
Thank you, sir.
So our next talk is classification of fundal varices. What should a clinician know And the speaker is Dr. Gaurav Chawla.
At the outset, I would like to thank Dr. Arora and his team for this opportunity. So, day in and day out, we tackle portal hypertensive patients with active bleed. This patient and SRH, and all the society guidelines recommend whenever active bleed is happening, the best therapy is cyanocolate glue injection. And here we are doing that cyanocolate glue injection, and that lead to the obliteration of the varix. So, why these classifications are important? Because usually gastric varices are a complex connections between the portosplenic venous system and the systemic veins of the abdomen and thorax. And the main problem is the heterogeneity of these shunts, which leads to the problems and leads to the different methods of tackling these shunts. Usually gastric varices are seen in 1 in 5 patients of portal hypertension compared to esophageal varices, which are almost seen in 90% of the patients. And hemorrhage from gastric varices usually have an incidence of up to the tune of 45% at 3 years and is associated with higher mortality. So the classification of gastric varices are two. There are endoscopic classifications and there is a radiological classifications. So endoscopic classification and the most widely used classification is the serine classification, which is based on the location of the varix. So we have GOV1, in which there is esophageal varices as well as gastric varices. And in GOV1, we have varices along the lesser curve along with esophageal varices. In GOV2, we have varices along the greater curve along with esophageal varices. Then we have IGV1 and IGV2, which are isolated gastric varices. And we have only fundal region varices will be there. And IGV2, in which we have antrum, there will be varices. So what is the importance of serine classification is that it has implications on therapy and hemodynamics. Basically, GOV1 can be managed as a esophageal varices because the drainage is entirely into the thorax, so you can just do band ligation and you can get away with that. The problematic is GOV2 and IGV1, which have distinct vascular supply involving short gastric, left gastric, posterior gastric, that needs proper evaluation management, and distal gastric varices or IGV2 can be managed separately. So, new recommended endoscopic classification, which has been given by American Gastric Association, is label them as either cardiofundal varices, which involves IGV1 and GOV2, which has a distant vascular supply, which are difficult to manage, or GOV1, which they call as lesser curve varices. To call them as lesser curve varices. And third is distal gastric varices, which are very rare, usually associated with splenic vein thrombosis in a non-cirrhotic setting, and these patients may be managed by just stenectomy also. So, coming to the problems with serine classification is that it doesn't take into account which varices will have risk of bleed in the near future, as we have for esophageal varices, the North Italian Club classification. So Hazizome, what they do, they look at the form of the varix, whether it is F1, which is tortuous, F2, which is nodular, or F3, which is tumorous. Again, they take into account the location of the varix, whether it's anterior, whether it's posterior, whether it's along the lesser side, along the greater side, along the fundic area. And third is the color of the varix. So whether there is white color, red color, or they have taken into account the focal redness, which is the most important, which is called the red color spot, which may have sign, which may bleed in the near future, and the size of the large size. These two are, if they are present, they may consider for even primary prophylaxis, and they may have signs of rupture immediately. Now, this is one of our patient in which we are putting seeing the fundal varices, putting a 19-gauge needle, and then putting a coil inside this varices, and then we are putting glue also inside this varices. So now we have put the saline first, just to keep our needle patient. You can see a echogenic coil which has been now delivered into the gastric varices. And after this, we'll be injecting a glue, and then we can do. So the third classification, why I'm bringing this, is Arakawa classification, which is very important for an endosonographer. So type 1 Arakawa classification is just a single large vessel which is supplying entire the gastric varices, and type 2 is a diffuse gastric varices. Let me show you with this figure. So this yellow part, if you see, is the extraluminal part of the varix, and red part is the intraluminal. And when we do slightly anti-clockwise, you can see the entire yellow part is supplied by this red part, and if we target this red part and give therapy of glue or coil to this red part, the entire varix may go down. And in type 2, which is a diffuse type, this is the luminal yellow dot is the luminal part of the varix, but extraluminal, you can see there are many collaterals to this varix. Even you can make out that there is a linorenal shunt with their blue dot lines. So these have therapeutic implications, and the way we target, the advantage of using US is we'll use less amount of glue, we'll use precise amount of glue, less chances of systemic embolization is there. We are able to inject coils through EUS, and that will lead, and we can also assess the variceal obliteration using Doppler flow. So the one you saw was a transesophageal, transmuscularis propria approach, which I showed on video. You can do transgastric, transsubmucosal approach. In this, we have the direct puncture of the varix and embolization technique, which we have done. But if you can identify a feeder vessel which is leading directly to this shunt, you can do transesophageal, transmuscular approach and directly do feeder vessel embolization. That will lead. Now, what is the importance of cross-sectional imaging? As I told, vascular anatomy of GV, gastric varices, is highly variable, and one treatment option may not work. They may bleed at low portal pressures. So cross-sectional imaging in the form of triphasic CT scan, especially we are interested in CT or MRI during the portal venous phase, that will give the best picture for planning a definite therapy of gastric varices. And it should be a multidisciplinary approach between interventional endoscopists, interventional radiologists, and hepatologists, and then only the best outcomes can be there. So coming to radiological classification, this is the Kyoto classification. In this, they have what is the afferent to the gastric shunt. So in type 1, there is a single afferent of left gastric vein. It's an easy one, you can be tackled easily by BRTO. Type 2 has a shunt of left gastric vein, but there also a posterior gastric vein which is involved. So it's a multiple afferent veins are installed, and we have to sort out what all veins could be tackled during IR procedures. And type 3 is another special type in which there is a shunt bypass afferent. So if you see there is from splenic vein, there is a shunt going which is directly feeding it and which is bypassing the gastric varices. So BRTO, if we do this patient, our sclerosant will go into the portal system and there will be decreased efficacy. Now in this there is an efferent venous outflow. We have talked about afferent to the gastric varices, there is an efferent. So in this efferent type A, there is only one portosystemic shunt, which is gastrorenal shunt, which is the outflow tract. In type B, apart from gastrorenal shunt, you can see collaterals going more. So apart from that, there are many small portosystemic collaterals. Then in type C, there are multiple large portosystemic shunts. Apart from gastrorenal, there may be gastrocaval, gastropericardial. So these are the ones which may be difficult to tackle. You may have to do BRTO, TIPS, even endoscopics, and tackle all the shunts. And then there may be just type 4, which there are small portosystemic collaterals as the drainage pathway, and we can just get away with endoscopy. So it looks like very complicated Kyoto classification. So what we can do is a Sart-Caldwell classification, which is very easy to remember and which very correlates with serine as well as new endoscopic classification. So here you can see you have to remember lesser gastric vein, posterior gastric vein, short gastric vein, and the site of the varix. So in type 1A and 1B, so it correlates with lesser curve gastric varices, type 1A, and without any fundal varices. Always, whenever B comes, means gastrorenal shunt is there. So it's gastrorenal shunt plus type 1A is type 1B. So it correlates with serine classification of GOV1. Now, type 2 correlates with fundal gastric varices or distal gastric varices. You can see the supply, they are mainly from short gastrics as well as posterior gastrics. So they have isolated fundal varices without any cardiac extension. So they correlates mainly with IgB1. Type 3A correlates, it has combination of 1 and B. So patient will have both esophageal varices as well as fundal varices. And it is high association with esophageal varices. And whenever B comes, you have additional gastrorenal shunt present, and this needs to be tackled, that shunts need to be tackled. So apart from this, there are other classifications which on-table intervention radiologists do, while doing BRT, which we call Hirota classification, which will depend upon the opacification of gastric varices. If it's grade 1 and grade 2, they can be just managed by endoscopic, but if they are grade 3 and grade 4, in which there's no staying of contrast in the gastric varices and all dissipation happening the collaterals, then they may require TIPS. In the interest of time, I'm not going into detail, and then this is one of the classification of BRTO, and then we have Fukuda classification, in which they do superior mesenteric and celiac angiography in the setting, and they found which system is dominant. Left gastric vein dominant system is there. There is separation between esophageal varices and the gastric varices, or there are highly complex systems involving both right and left-sided feeding vessels, or they may right side dominance. Based on that, what type of therapy to be done, tips is only a session, tips with BRTO, on all these things, decision can be made by them during the process of one of the complications. Just I'll take another 30 seconds. So one of the problems of BRTO is aggravation of esophageal varices. So that also they have thought about, and what they see what is the flow in the gastrorenal shunt. If there is flow present or type 1, if there is no flow present, there is good. So only type 1B has 30% chance of aggravation of esophageal varices, where is a hepatofecal flow happening at the portosystemic shunt, gastrorenal shunt. So this is the algorithm for gastric varices bleeding. First, see what is the site, whether it's lesser curve or cardiofundal. Active bleed, cyanocolloid injection is the best thing. If there is no active bleed, try to get the imaging, cross-sectional imaging using portal venous phase, and try to classify what is it. Then based on that, if it's SART classification type 1B, you can just manage like a esophageal varices. If it's type 3A, 3B, you may need tip with embolization or cyanocolloid glue. Or if it's a type 3B, then you may need a BRTO. Similarly, type 2A can be managed only by cyanocolloid injection. Type 2B, because always it has a shunt, requires BRTO. And type 3A and 3B may require a combination of things. Apart from BRTO, you may require tips and cyanocolloid glue injection. So I'm just with that, I'll just say thank you and end.
Thank you, sir. So for our next talk, I would like to invite Dr. Randhir Sood. The topic is management of non-variceal portal hypertensive bleeding.
Thank you, Anil, for inviting me here today morning. Well, this is a little unusual topic, but we encounter it rather frequently, and we need to have our plan of action very clear. So we have basically two areas which I'm concentrating. When you talk of non-variceal portal hypertensive bleed, people include ectopic varices, which I have not tried to include in this because that would have stretched the scope of this talk. So it is either, gastric antral vascular ectasias, that is GAVE, or portal hypertensive gastropathy. And this can be mild or this can be severe. And there could be nodular portal hypertensive gastropathy. And all these can lead to, blood loss, either chronic or acute bleed. There are two distinct entities. The GAVE is present, cirrhosis accounts for only 30% of the GAVE. There are other etiologies for GAVE, like autoimmune disorders like scleroderma and other autoimmune diseases. CKD is a very common cause, and post-bone marrow transplant as well as hypothyroid state are common causes of GAVE. On the other hand, portal hypertensive gastropathy only happens in presence of portal hypertension, particularly cirrhosis, and certain types of, certain etiologies are more associated with portal hypertensive gastropathy. Degree of decompensation is associated with, size of varices is associated with portal hypertensive gastropathy, and occlusion or treatment of esophageal varices is also associated with increased incidence of portal hypertensive gastropathy and its bleeding. When you talk of the management, these are totally different. There's no need for primary prophylaxis like for esophageal varices if you see portal gastropathy, and it's also not needed for GAVE if you just happen to see it on endoscopy, unless patient is anemic and you have iron deficiency anemia documented. Medication for portal hypertensive gastropathy is same as for variceal bleed, that is either beta blocker for prevention or in chronic phase, and octreotide or terlipressin in acute bleed. There's no evidence of efficacy of any drug therapy in GAVE. Endoscopy in portal hypertensive gastropathy is only temporary, not very effective, but yes, for acute tiding over the crisis, you can use endotherapy, and this is APC or hemospray. On the contrary, for GAVE, endotherapy is the mainstay, and I'll come to later in detail. In severe portal hypertensive gastropathy, you again resort to the same mechanism of reducing the portal pressure either by tips or portosystemic shunts. And in GAVE, if it is very severe and recurrent blood loss, surgical enterectomy is an option, provided patient is stable and fit enough. So in short, medicines have a role in portal hypertensive gastropathy, and endoscopy has a role in GAVE. Let's just see what is how significant is the role of endoscopy in portal hypertensive gastropathy. Two modalities have been tried, either hemospray or APC, and you can see that there are very small studies, hardly 11 patients in APC group and 4 patients in hemospray, so you cannot conclude much. But this was successful in almost 80% patients, and there was no recurrence in after APC follow-up. But we have tried APC in portal hypertensive gastropathy bleed. It has been frustrating, except for cessation for a day or two. So limited study, strong belief that endoscopy doesn't work. So don't waste your time on it. On the other hand, for gastric GAVE, it counts for 4% of the non-variceal upper GI bleeds, and commonest site is antrum. But let me tell you, vascular ectasias can happen in cardia, duodenum, and jejunum, and it is commonest associated with cirrhosis liver and other conditions which I mentioned, and may present either as a frank GI bleed and mostly as melena, hardly ever as hematemesis, or as refractory anemia or iron deficiency anemia. And treatment, endoscopic therapy is the first line, and there are two which I am going to mention in detail. That's argon plasma coagulation, endoscopic band ligation, and to some extent radiofrequency ablation. Cryotherapy and ND-YAG laser have been tried, effective, but not much in use, so we don't have much evidence for their efficacy. Systemic therapy is no definite proof of efficacy. So we do APC. We use, everybody is familiar with what argon plasma coagulation is, the superficial non-contact thermal ablation of these ectatic vessels, or we turn the melon into grapes. There's the endoscopic band ligation for watermelon stomach. So I like this terminology of melon turning into grapes. So you do band ligation. We'll see their efficacy. Or you use the RFA probe, particularly Helio 60 or 90 or XL, and you can get good contact ablation, but it is expensive, and the cryo has been tried, but limited studies available. Let's look at the commonest modality which all of us use in GAVE, that is argon plasma coagulation. The successful ablation in various studies has been quite encouraging, from 40% from GURG series to 100% in quite a few studies. So I'll say on average 70 to 100% immediate hemostasis can be achieved. The blood transfusion requirement substantially decreases with after APC. The problem is that there is a significant recurrence rate. In fact, anything up to 79% patients will recur after ablation with APC. So that's the frustrating part, and adverse events are not less. They're up to 20%, but they're minor. They're mostly nausea, vomiting, and epigastric pain. But episodes of sepsis and gastric outlet obstruction have been reported in literature. So again, depending on the type of GAVE you're treating, it is more effective in diffuse GAVE, and which is characterized by small lesions, and incomplete coagulation happens in striped GAVE. And Nakamura has studied 22 patients with endoscopy every 3 months, and you see the 1 year recurrence-free rates is only 50%, and 2 and 3 years are just 1/3 of the patients are recurrence-free. Most of them will recur again. They have been attempted using hybrid APC and combination with polidocanol with some success, but very limited data. So let's come to the RFA in GAVE, and you can see that small numbers, but clinical success has been up to 70 to 86%. And all had previous treatment with APC. So when APC fails, this is one modality you can depend upon. And the advantage of RFA is it is a contact therapy, and it is actually restricts the enteral motility. So you can have wider area of ablation. In fact, with RFA Helio 90 XL, almost 5 centimeters can be ablated at one time. So, and there's no RCT comparing APC and GAVE. There's only one retrospective study of 24 patients, no significant difference. So let's come to the band ligation, which is the coming up more and more, and endoscopists always prefer something which is new. And these are 2 prospective trials, and show a significant success rate of 91%. And it required significantly less sessions and less number of transfusion when you treat patients of GAVE with endoscopic band ligation. And this is the bird's overview of the GAVE, EVL in GAVE. You can see it's limited, much less data than APC, and the blood is again as successful as APC. And you know, there are 2 randomized control trials comparing APC with EVL. The only thing is that the less treatment sessions are needed, lower amount of blood transfusions are needed in the largest trial published. And another trial which was published this year from Egypt, again highlighted that fewer endoscopic sessions needed. So I think EBL needs to be considered in management of GAVE today. We have started doing both a combination of APC plus EBL, and these are both effective. There is a trial available which shows it decreases the number of banding sessions, decreases the number of bands required, and decreases the incidence of band-related complications. But when we do EBL very close to the pylorus, patients do develop symptoms of gastric outer obstruction, and you have to manage them for first 2 to 3 days with prokinetics. Systemic therapy is uniformly disappointing. So to conclude, GAVE and PHG are different. Reduction in portal pressure in PHG and endotherapy in GAVE are the mainstay of treatment. There is limited utility of endotherapy in PHG, so don't waste your time on that. APC is the most widely used modality with has high relapse rate and dependence on transfusions. EVL is a good alternative. RFA is emerging therapy, and we need further research and validation required before we recommend other therapies than APC. But I think EBL plus APC will stand the test of time. Thank you very much.
Thank you, sir. The house is open for questions and answers.
Hello.
So shall we stay here?
Is there a...
Okay.
Sir.
The average band requirement will be around 10 bands. You will use 2 sets which will have 6 in each, so you will do 10 to 12. Over-aggressive banding will cause gastric outer obstruction, and you should always identify after band. You should go into the duodenum, so to see that you have not blocked the pylorus.
And sir, you do APC first or you do the banding
We do banding first, and we do APC. I did not show you the videos because the time was short. What we have started doing is that after on 3rd day after banding, we go and do the APC.
Is there any INR cutoff before we do APC?
Oh, not at all. There's nothing, no INR, no platelet count, which is important. Because
Even for
thermal modality, it doesn't cut.
Even for EBL?
No question. Do you have any INR restriction for EVL band ligation in esophageal varices? You have not.
But there will be big ulcers after EBL in this case.
There are ulcers even in esophagus. So you have to do band ligation, and fortunately you can. That's why I'm saying that we go on day 3 after EBL and do APC. And we do find ulcers there, but they are not bleeding most of the times.
So what about the diffuse duodenal lesions sometimes we get?
Yeah.
So how do we treat
those? Just presence of lesions is not important for therapy. If there is iron deficiency anemia or bleeding, then you have to differentiate whether it's a nodular hypertensive duodenopathy or it is GAVE. If it is GAVE, then APC. If it is hypertensive gastropathy, immediately you may do APC or band ligation. In duodenum, I'll caution against band ligation because you can go transmural. So, there your strategy will be to reduce portal pressure.
So they commonly coexist, the GAVE and PHG, severe PHG?
Common?
Coexistence, both together?
They can coexist, particularly in cirrhosis.
Sir,
yes.
My one question is to Dr. Gaurav Chawla. It was a very nice talk. But Dr. Gaurav, many of us are doing endo-ultrasound, but still gastric varices are managed by endoscopy still. So we have been now more wiser that extraluminal as well as the anatomy of shunts is very important before embarking on the therapy. So do you think cross-sectional imaging is a must before doing a therapy for gastric varices? And if yes, how safe is doing endoscopic glue right now?
So as I told Arvind in my first slide, on my final slide also, first if patient is actively bleeding, the best modality is endoscopic glue obliteration. But if it is large varices, stable patient or patient has recurrence, then definitely you need a cross-sectional imaging to do what is best can be done. If there are no major shunts involved, then endoscopic glue coil, I think, is the way to go. But if there are many, like type 2 Arakawa, there are many efferents to the shunt, then we have obliterated part of it, but then we should make a multidisciplinary team with IR also involved, what best they can do, what they can obliterate, and then final decision should be done with a multidisciplinary team involving IR, hepatologist, as well as interventional endoscopist. But if patient is actively bleeding, endoscopic glue has to be done as initial.
Gaurav, are we overzealous in treating sometimes fundal varices? If you on endoscopic ultrasound do not have any flow signal in any of the varices, do you need to actually go to the feeders?
Yes, sir. Yes,
Why don't you do that for esophageal varices? Because that's what I'm asking. Is there evidence that there is increased risk of bleeding if you do not treat feeder, particularly when you have obturated the fundal side and there's no flow signal on a US?
Sir, but only we are treating when their patient is having recurrence of bleeds. If patient is settled and if patient has no recurrence, no need to evaluate. But if patient has recurrence of bleed, definitely there is a collateral or there is a efferent which is blocked, which needs to be tackled, and then we need.
But then you will have a flow signal on EUS.
Yeah. So, sir, most of time when we do EUS, they have a flow signal with them. First time we have done, there's blockage, but then subsequently, sir, after any endotherapy guidelines say we have to re-evaluate with endoscopic ultrasound after 4 to 6 weeks, and even with cross-sectional imaging, what is happening. There may be new collaterals developing with time with the advancement of portal hypertension.
So my question is to Randeep, sir. Sir, actually portal hypertensive gastropathy bleeding are very frustrating because they usually present with chronic mild ooze and patient is having chronic or recurrent anemia. And if the patient is not tolerating beta blockers or beta blockers are not effective, as you said, endotherapy is not much effective in this entity. So how do we tackle them if the patient is not fit for transplant or not willing for transplant?
Tips.
Tips is the option.
Yep, that's an option. You need to lower the portal pressure. If you can't do it with the pharmacological methods, you will need tips for that if that transplant is not an option.
We never knew, that you made gastric varices, so mind-boggling. There's so many classifications coming up. What exactly, whenever you see a gastric varix on an endoscopy, do you jump onto treating it or you just keep on following?
Sir. So data is very clear, sir. For primary prophylaxis, best treatment is non-selective beta blockers. As I told, if there is very large varix or there is red color sign, then I may consider this data. Actually, whatever data we have in gastric varix, it's limited by case series, small randomized control trials with selection biases and cohort series. So we don't have a very good, it's difficult to do also the large good data. We don't have one over the other, but we can make science more into the by analyzing, and we should not touch only if it's not bleeding. Primary prophylaxis, best treatment is non-selective beta blocker.
So any more questions? So I think we had a great question answer session, and with this session is concluded. Thank you.
So moving on to the next session, which is improving pharmacological outcomes in common GI disorders. The moderators are Dr. Arvind Namdeo, Dr. Randeep Rana, Dr. Ganesh Pal, Dr. Manish Manrai, and Dr. Yogesh Batra. And the chairpersons for the session are Dr. Anira Vaidya, Dr. Sabeen Raj Bhandari, Dr. Alokit Gulati, Dr. Rajesh Shukla, and Dr. Saroj Dubey. And the first talk for this session is My Belly Hurts, Optimizing Treatment of Abdominal Pain by Dr. P.K. Agarwal.
Very good morning to all. A very large topic. I do not know how to optimize the topic itself. Thanks Anil sir, Dr. Ashish and Dr. Praveen, for giving this opportunity. I do not know how much justice I will try to do, but let me just go ahead and start with it. So in 3 days' time of this extravaganza of this conference, a lot has been learned, and then now we are today back to basics. So back to basics today, I think, after reading too much of hepatology and other parts of gastroenterology, so today we see what exactly happens when the abdomen pains. So the key components as we all are busy practitioners, the only idea behind is the single word, that is give time to your patient so that you can really find out what's happening in terms of either age, sex, the type of symptoms, the duration of symptoms, the characteristics of pain, so on and so forth. Many key terms, we normally use very loosely at times, like acute abdomen, acute abdominal pain. Are they both same? No. The biliary colic we all know very well. The chronic abdominal pain, if anything, in more than 6 months period. And of course, the peritoneal pains, which we normally try to forget that which viscera or the pelvic area has been absolutely innervated by what nervous system. Many times we say the patient has got a referred pain, but from where it is coming? Somatic pain hai, visceral pain hai, whatever. So, this abdomen, which is a real jukebox, as the neurologist says about the brain, whether it's a left quadrant one or a right quadrant one, the lower abdomen one, we need to really classify that. So let's have a little bit of, a minute or so on the causes of left upper quadrant pain, which we all know is all because of splenomegaly. Splenic infarct is too less common. Splenic abscess, not very commonly seen. Splenic rupture, of course, and only in terms of traumas. A right quadrant pain normally comes up with either a biliary colic, the patient having an acute cholangitis, if we get a Charcot spread in the form of pain, fever, and jaundice. Because of liver, could be because of acute hepatitis, or because of the Fis-Hugh syndrome, which is a perihepatitis system. Portal vein thrombosis doesn't usually make a clinical diagnosis until unless the patient has got in the background cirrhosis. Epigastric abdominal pain. Every patient in the clinic today comes with what you call as an epigastric abdominal pain. Now, at times we have seen that patient who comes saying that mujhe to gas ho rahi hai, turns out to be a myocardial infarction. Acute pancreatitis, of course, comes up very nicely. We all know that as soon as you see the patient jumps with the tenderness, the first diagnosis if the patient has got a history of some alcohol binge a day before or a few hours before. Possibility of pancreatitis is very high. Peptic ulcer disease, we all know, is of course there. And of course, gastroparesis is one diagnosis which one needs to keep in mind if the patient is a diabetic. Lower abdomen pain. Haath lagane ke baad mein we normally try to say nothing is there. But friends, appendicitis we all know we normally see. Nephrolithiasis, usually if the patient has got a pain around the uretrovesical junction. Patients with diverticulosis, we all should know that the commonest pain which happens is in the left lower quadrant, because the diverticulars are more found in the sigmoid colon and other places. And of course, in males, one should be very much particularly seeing about the testicular torsion. And in females, whether the lady has got a pain because of the periods or because of an ectopic pregnancy coming up, if it's a young lady of childbearing age. Diffuse abdominal pain, many things, could be a perforation of the gastrointestinal tract somewhere, and a patient with ketoacidosis, a patient with acute mesenteric ischemia. Such pains usually don't come to the clinics directly until unless there is a history in the background of it. Here I will not enumerate about the less common causes. It's a huge big list. But we should know that as gastroenterologists, we normally go ahead and find out what's called as a gastrointestinal cause. Most commonly diverticulosis, appendicitis, patient with bowel obstruction, some amount of perforated viscous. In young child, usually a Meckel's diverticulum, and of course volvulus needs to be kept in mind very clearly. Extraintestinal causes, at times we tend to forget in the busy OPDs, which is very much needed to be identified, especially about the urinary tract, the vascular complications, musculoskeletal pain. Here I will take a few minutes that usually we tend to forget that many a times if we don't find any organic cause of a pain, it usually turns out to be either an acnes, that is an acute cutaneous intraepidemic syndrome where a Carnot sign is more positive. The patient with a fracture, if you don't take away the cloth of a patient from the tummy part of it, you tend to even forget to see about the patient having an inguinal hernia or an umbilical hernia. Herpes zoster, most commonly missed. Patient says pain, we normally try to say that, okay, fine, you've got a pain out without organic cause, no peptic ulcer symptoms, or no APD or a functional dyspepsia, and usually comes up with what you call as an herpes zoster in the background, where the rashes are there which are never asked for. Abdominal epilepsy and abdominal migraine. These causes we are all very well versed with. Psychiatric illnesses, very finely known. Patients with sexual abuse and certain other interpersonal reasons, domestic violence and other things. Of course, it's not very common in our country now. Henceforth, pelvic causes, if you see a women, this slide I especially mentioned is that we normally need to know about when you take a history where the patient of childbearing age, about her menstrual cycle, the LMP is very important, which most of the prescription I would say should have endorsed, so that you can easily take off the ectopic pregnancy part of it, the patient with endometritis, ovarian torsion, and at times, if it's a pregnancy-related complication. If all organic causes are taken off, then what exactly comes is usually a functional dyspepsia. So what happens here is that if we are enumerating each and every cause, the functional dyspepsia is the only thing which comes up. Here the most important thing are the red flag signs. If the person is of more than 60 years of age, if the person has got some amount of odynophagia, or the person has got a condition called xylodikinia, where the muscular pains are normally there, or a slipping rib syndrome, so you need to treat accordingly in such patients. What exactly we need to see is that our algorithm of PQRST should be followed. Whether the provoking questions like whether your pain worsens on eating, whether on eating it alleviates your pain, the quality of pain versus a tearing pain or a crampy pain, the person has got an MASLD, if vomiting, the radiation, the type of pain, the severity which is there, whether it is there for a short period, few hours, or maybe for more period of time, and does it really hurt at its onset, especially in patients with aortic dissection, which is not very uncommon. So the timing of treatment basically depends on the diagnosis which you normally do, whether the pain is intermittent, worsening, could be a biliary colic or renal colic or small bowel obstruction, whether the patient has taken recent antibiotics and the pain has happened to occur in the flank area or the lower abdomen, we need to really rule out the C. diff, and does the pain occur in times to come up with vaginal spotting, especially in female with Middlesbrough syndrome. So friends, what exactly I wanted is that whenever we normally see a patient in our OPDs, we jump onto investigations. You go for blood test, blah, blah, blah. You go for a fecal cal, which is very common nowadays. You go for a C. diff toxins, A and B. You go for an X-ray abdomen, maybe a CT. And at places I've seen that even enterography is being done on a patient with abdominal pain. So if you really have ruled out all the causes, which I have not specially taken up any drug for the abdominal pain, because each and everything has been discussed, how you treat pancreatitis, how you treat a biliary colic, how you treat a cirrhosis liver, how you treat a varices, what exactly you do and all that. So taken into consideration, if everything organic is ruled out, it's probably a functional dyspepsia. And if that too is not being treated properly by giving your PPIs, H2RAs, etc., one of course nearly thing to have, you normally start with an antispasmodic, and what should be the dose. And the best ones which are available to us are mebeverine, octylonium bromide, pinavarium bromide, etc. And of course, if this pain is functional, then what exactly? If it's real functional pain, then we need to go for things like either SSRIs or TCAs. Amitriptyline is a wonderful drug which is to be used, but not on high doses as used by our psychiatrist friends. You should start basically, with a low dose system, even with SSRIs, because these things at times respond very nicely, but you need to wait a little bit patiently. Even counsel your patient about that this pain will take some time to go off. So the real guidance on optimizing the treatment is that you should start an antispasmodic, thinking of the system, the TCAs or the SSRIs. But friends, here there are certain caveats, because as I said, most of our patients with acute abdominal pain need a diagnosis of exclusion. The signs and symptoms, they should be heard very patiently, cautiously, and serial abdominal examinations at times change the diagnosis. The severity of the pain is usually underestimated when it's an elderly person. So give time and find out and take a detailed history, which normally most of our patients do not give. The underlying history of a cancer, the person having other diseases and many other things. So take a history properly, which really befits your diagnosis. At times the barriers are the native language, the emotional stress, the patient. Basically we are in a hurry to make a diagnosis where we normally have other problems. So the use of laboratory and imaging studies then are supplemented, but they are not most importantly done immediately on seeing the patient examination. Do we have time? A minute? Here are, I've just put in 3 cases that after hearing a history of it, what exactly should be diagnosis coming up? In a young male with no past medical or a surgical history, presents to an emergency department with abdominal pain with a fever of 101. 6 hours ago, he felt nauseated and began to notice a vague periumbilical pain that is now severe, the grade of 10 out of 10, with sharp migrating to the right lower quadrant. On physical examination, is febrile, restless, tender right lower quadrant. What is the most likely diagnosis? Testicular torsion, appendicitis, ischemic colitis, pancreatitis, small bowel obstruction. Perfect, sir. आपसे तो जीत ही नहीं सकते. A 48-year-old healthy obese woman comes to a clinic with 1-day history of non-radiating burning pain that started 2 hours after eating lunch, which she rates as 4 out of 10 scale. She describes the pain in the past few months but never severe. The pain has now worsened down. When lying in bed at night and has been relieved in the past by antacids. She denies of fever, weight loss, change in her bowel movements, or radiation to the back. The physical examination demonstrates normal vital signs and only notable for mild epigastric tenderness. What's your diagnosis? Cholecystitis, pancreatitis, peptic ulcer, aortic dissection, celiac sprue. Most likely peptic ulcer, but of course, sir, one should also have the diagnosis of a biliary colic in mind at the back of it. The last case, a small one, 30-year-old alcoholic man with no past history of surgical or history, brought in an ambulance to the emergency department with severe pain, other grade of 7 out of 10. The pain started 5 hours after the ingestion of a large meal, radiates to the back, associated with nausea with no bloody non-bilious emesis. Denies of any problems in pain with micturition. On physical examination, he is afebrile, tachycardic, tender, without rebound epigastric pain and left upper quadrant. What is the most likely diagnosis? Pancreatitis. So I think, I was probably able to give some insight, about the abdominal pain. It means a fast history can also give you the diagnosis. Thank you.
Thank you, sir. So our next talk is when to choose PCAB over PPI in acid suppression by Dr. Nandu Podyal.
Thank you, Anil Arora and his team for giving me an opportunity to speak on a talk when to choose PCAB over PPI in acid suppression. So basically, I'm going to speak on this topic. So let's start from the beginning. When there is old dictum is that no acid, no ulcer, but new dictum is that when there is H. pylori and NSAID, ulcer results from the imbalance between digestive action of gastric acid and protective forces of the mucosa. So when there is a mucosal incretin and for the acid secretion, there are 3 pathways: neural pathways, paracrine pathways, and the hormonal pathways, which is stimulant of acid secretion. But for the mucosal incretin, depends upon a delicate balance between defensive and offensive forces. So mechanism of action of PCAB, it basically acts on the potassium binding sites in the parietal cell that's required for the hydrogen ion for the production of the acid secretion. So why we need newer anti-secretory drugs is that PPI takes several days to show the maximal effect, and reflux symptoms of GERD and healing of erosive esophagitis are not sufficiently achieved. 40% do not respond to 8 weeks therapy of PPI, And this also effect on CYP, 2C119 polymorphism, unsatisfactory response at night, unstable in acidic conditions, short half-life, and there is fasting state is required. Though there is in the PPI, there is immediate release of omeprazole, dexlansoprazole, but 24-hour pH secretion for more than 5, even after 5 days, dexlansoprazole was only 71%, while that of lansoprazole is 60%. So now is the time for the PCAB. And this PCAB, it affects from the first dose, and it remains its effect throughout the day, while the PPI requires 3 to 5 days to reach the maximal effect. So how it was involved? In 19th century, there is lifestyle intervention. In 1970s, there is S2RA receptor was there, and present PPI was started in 1980s. But in 2015, vonoprazan first PCAB was introduced in Japan, which is FDA approved. Later, tegoprazan, fexoprazan, and cariprazan was introduced. So how it was developed, though there is a concept of since 1980s, but due to its hepatotoxic effect, it was not produced. Even linaprazan is the phase 2 and phase 3 trial is stopped due to hepatotoxic effect. Later, rivaprazan was introduced, but it is not superior to existing PPI. So vonoprazan was first FDA approved PCAB. Subsequently, it's used in more than 15 countries, with later tegoprazan, fexoprazan, and cariprazan was introduced. So what's the difference between this PPI and vonoprazan is that acid stability is present with that of vonoprazan, while it's PPI, and main difference is time of administration is 30 to 60 minutes before meal, while it's food independent with that of vonoprazan. Half-life is 1 to 2 hours with PPI and 6 to 9 hours with vonoprazan. Onset of action is delayed with the PPI, while it is rapid in vonoprazan group, and 24-hour acid suppression is not achieved with the PPI, while it is achieved with that of vonoprazan group. And CYP2C19 interaction is present with the PPI, while it's not in the vonoprazan group. So main indication of PCAB is usually present in the refractory GERD, erosive esophagitis, non-erosive reflux disease, peptic ulcer disease, and bleeding peptic ulcer. So PCAB in refractory GERD, and different studies they have shown that if it is not responding with the twice daily PPI therapy for minimal of 8 weeks, then we can use the vonoprazan. And this is also supported by JST and the ACA guideline 2024. So PCAB in erosive esophagitis, and this is in the mild erosive esophagitis, LA and B, ACA guideline 2024, they have shown that PCAB may be used in selected patients who failed therapy with a PPI dosing, while for the C and D, JSC 2021, ACA 2024, and EPI 2025, they recommended vonoprazan as an initial treatment approach for severe erosive esophagitis. So this is a trial which is done on vonoprazan and lansoprazole group, which also shows that in the healing phase, vonoprazan has 92.9% effective, while lansoprazole 30 milligram is 84.6% only. While in maintenance phase, vonoprazan has 80% response, while that of lansoprazole is only 72%. So this is another trial which also shows that this PCAB is inferior than that of the PPI group. And it is also used in non-erosive reflux disease, which is shown in Falco NOD 301 trial, where they have used as vonoprazan 10 to 20 milligram. And JSC also supported this. PCAB, like vonoprazan, may be effective in NOD with excessive esophageal acid exposure. And recently in ACG 2024 guideline, they have also showed in the H. pylori eradication. With the treatment-naive patient, vonoprazole dual therapy was used with vonoprazan 20 milligram and amoxicillin 1 gram per TDS for 14 days. But in the proven antibiotic-sensitive case, vonoprazan triple regime was used. Vonoprazan 20 milligram with clarithromycin 500 BD and amoxicillin 1 gram BD for 14 days. So there are different trials. We showed that ACA 2024, they have shown that the PPI in the eradication regime for most of the patients with H. pylori infection, PCAP should be used in place of PPI. Matrix 7 and Fluorescent 2024 consensus, they have shown PCAP-based therapy HP superior, not inferior to or conventional PPI-based therapies. And systemic review of 7 Asian RCT, they have also shown significantly higher eradication rate in first-line treatment for vonoprazan versus PPI 92% versus 80%. And there is 1,046 patient treatment in American and European adult. They have shown vonoprazan-based dual therapy versus triple therapy versus PPI, and which is shown that 81% versus 77% and 66%. So vonoprazan-based therapy demonstrated a marked superiority over lansoprazole-based therapy. So this PCAP is also used in the peptic ulcer disease. There's also another trial, Japanese RCT and Korean RCT trial. And they have shown that the ulcer etiology may affect treatment success, healing of HP-associated peptic ulcer disease, idiopathic and NSAID-related ulcer. PCAP may be useful in PPI refractory ulcer. So PCAP in bleeding peptic ulcer, RCT assessing vonoprazan compared to PPI for the prevention of high-risk peptic ulcer rebleeding after endoscopic hemostasis. Vonoprazan 20 mg BD for 3 days followed by 10 mg OD for 28 days versus pantoprazole 8 mg for 3 days followed by 20 mg BD for 28 days. So 30-day rebleeding rates were similar in two groups, 71% versus 10.4% respectively. So vonoprazan was considered non-inferior to the pantoprazole. So this is the long-term safety of the PCAP, and this is a long-term trial, the Vision trial. They have shown 5 years open-label RCT trial, and they have also shown that only the parietal cell hyperplasia, fibular hyperplasia, and similar rates of ACL hyperplasia and G cell hyperplasia, but there was no increased risk of malignant transformation or gastric need. And drug-to-drug interaction also done in 16,145 patients with more than true antithrombotic agent. Vonoprazan was non-inferior to PPI in terms of UGR bleed occurrence at 6 months. And with the common adverse event is also seen between these two versus PCAP versus PPI, which is also shown is the non-inferior than that of the, and it's a similar incidence between these two, PCAP and PPI. So PCAP, it should be used for H. pylori eradication for most of the patient, may be used for the healing and maintenance of healing LAC and D erosive esophagitis, BIT PPI failure in confirmed GERD, peptic ulcer disease refractory to PPI therapy, uncertain potential utility on demand therapy for heartburn symptoms, peptic ulcer bleeding and high-risk stigmata, should generally be not used as a first-line therapy for uninvestigated heartburn or non-erosive GERD, first-line therapy for LAA and B erosive esophagitis, first-line therapy or prophylaxis, so basically used for GERD, H. pylori treatment, and peptic ulcer disease. So my take-home message is PCAP achieves rapid, potent, and prolonged acid suppression. Prolonged acid suppression also extends to H. pylori eradication with erosive esophagitis and secondary prevention of NSAID, gastropathic, and become established indication for vonoprazan. The most important indication for upper GI non-variceal bleeding, but when vonoprazan is likely to outweigh the benefit of drug-resistant PPI has yet to be explored. Thank you.
Thank you, ma'am. And our next speaker is Dr. Naresh Bhatt, and the topic is IBD in pregnancy, navigating treatment without compromise.
Good morning, and thank you, Anil, for having me here. IBD and pregnancy is a difficult area because women who are pregnant are automatically excluded from all drug trials. And so we have very, very little data or low quality of evidence to take decisions. And it's the credit of these two mothers and IBD specialists, Dr. Uma Mahadevan and Dr. Mara Dubinsky, who've put together whatever data
that could be accumulated across most centers in North America and have given very clear guidelines, which I'm going to share with you today. We all know that IBD in pregnancy is associated with poor outcomes, starting right from higher infertility rates, decreased conception because of various factors, including anatomical. Then you have premature deliveries, abortions, you have intrauterine growth retardation, and so on and so forth. So when you approach pregnancy in a patient with IBD, you have to go through the whole gamut, starting from preconception to pregnancy in all its 3 trimesters, look at the delivery and beyond, that is vaccination and well-being of the infant. So obviously there has to be a multidisciplinary sort of management with the obstetricians, as well as shared decision making with the patients. Now the important issue is, are all stakeholders comfortable? A survey showed that most gastroenterologists have good theoretical knowledge and good on paper, but when it came to managing clinical patients, there was a big gap. Obstetricians and GPs obviously fared worse for various reasons, and patients, majority of them claimed that they had never been counseled, or even if they had, they never understood anything. So there is a huge unmet need at all levels that we need to address. Now, preconceptional, there are many, many issues from the patient's point of view. One, of course, is, can I get pregnant? Is there a risk for the baby of getting IBD? Is the medicine safe during pregnancy? Is my disease going to worsen? And so on and so forth. So there will issues, and all these need to be addressed. And we know from across disease spectrums that any strategy of preconceptional counseling leads to better outcomes, and IBD is no different. So one must focus on preconceptional counseling, encourage them to get pregnant if they wish to, because a lot of them have apprehensions and fears, and one must allay those anxieties. Now, if you look at the natural history of IBD in pregnancy, we tend to believe that yes, the immunogenicity is a little less, or most immune diseases are a little less aggressive in pregnancy. But yes, even then, their flares are known to occur. If someone has a quiescent phase before they conceive, then the flares are much less. But if there's active disease, the flares are very high, up to 40 to 70%. So the big takeaway is you must achieve a stable, deep, steroid-free remission for at least 3 to 6 months prior to conception, which means your role starts much earlier. So get the disease under control, and that is the big message. So remember that it's not just getting the control, but we also need to have safety of medicines taken into consideration. And so obviously there would be medicines that you'd like to avoid at the time of conception, and that can be sometimes as long as 3 months before they conceive. This is especially for JAK inhibitors. So that is something that you'll have to talk about. We'll have to talk about what happens in the during pregnancy and so forth. So if you look at drugs in pregnancy, if you look at the first column is preconception, most of the drugs that are safe at that stage are safe throughout pregnancy and during lactation. Methotrexate, JAK inhibitors, CYP modulators are definitely not something that you would want them to be on. And as I said, for JAK inhibitors, even up to 3 months before they conceive, you may have to stop the medication. For the others, for the CYP modulators, maybe 4 to 6 weeks is okay. But so optimize the therapy much before, get them into a remission, and avoid some of these drugs before conception.
Then if you look at the other drugs, the methotrexate is out throughout, JAK inhibitors, CYP modulators out throughout the pregnancy and during lactation. How do you manage an acute flare? Antibiotics, short term, no problems. 5-ASA, generally safe, especially the mesalazine. Usually, sulfasalazine is something that is not strongly recommended. Steroids are safe in the short term, but preferably avoid in the first trimester. You may prefer to use budesonide rather than prednisolone. In fact, anti-TNFs may be better than long-term steroids. There's a very big message here. You can use vedolizumab if you want with short-term steroids. Thiopurines are generally safe during pregnancy, but the recommendation is if they are already on it, fine. But do not initiate a thiopurine during pregnancy. I think because data is very scant on this, so it's not safe to start them during pregnancy. If they are on it when they are conceived, please go ahead and continue that if it is required. Monitoring in pregnancy, obviously you go by symptoms. Hemoglobin, CRP are not very reliable. You can use a fecal calprotectin or bowel ultrasound in the first 2 trimesters. If you need to do a sigmoidoscopy MRI, use it if absolutely essential. But obviously, you need to take care of nutrition, folic acid, vitamin D, iron, all this has to be taken care of. Drugs like allopurinol, methotrexate, strict no-no. If you're using one of the 5-ASAs, avoid Asacol because there is some concerns about skeletal abnormalities with the dibutyl phthalate that it contains. As I said, citalopram is not recommended. You can use the conventional 5-ASAs or mesalazine without any fear. Tofa, like all the JAK guys, as I said, and cyclosporin and ciprofloxacin, especially in the first trimester, try and avoid. So there are some things that you need to avoid, but there's a few and it can be easily remembered. There has been a lot of issues about biologics and their safety in IBD pregnancies, but thanks to the Piano registry, they actually have great data on this, and it's shown that IVD women on biologics have no different outcomes than the general population. So biologics are safe not only throughout pregnancy, but even thereafter. Delivery, standard indications for C-section or active perineal disease, or if they have a rectovaginal fistula and so on. You can restart medication very early after delivery. Lactation, same thing. What you continued, you can, during pregnancy, can be continued to lactation. The only problem is on biologics and infections and risk of vaccination, because your immunity in the baby is also low. So there have been reports of when they have been given BCG, there has been active tuberculosis or disseminated tuberculosis leading to even some deaths. So a very big word of caution on the use of BCG vaccination before the age of 6 to 12 months. Minimum is 6 months, but preferably 12 months. We also recommend lactation, breastfeeding for at least 1 year of the baby to minimize the risk of IBD in the progeny. Venous thromboembolism, extremely important because both pregnancy and IBD are both thrombophilic states. So assess VT risk factors. Active IBD flare, any hospital admission, any surgery, high BMI, history of thromboembolism or thrombophilic states, start LMWH and continue for a period of time, as I've stated there. If the risk is low, then you don't need LMWH, just take basic precautions of mobilizing and hydrating. So the key messages: control disease first. Remission at conception is a great way to start the pregnancy. Most IBD medications are safer than uncontrolled disease. And of course, educating our obstetric colleagues and a team approach and involving the patients in the counseling are paramount. Thank you.
Thank you, sir. Sir, I would like to ask one question, Dr. Naresh, sir. This side. Recently had a patient who presented in 4th month of her pregnancy, was maintained well on tofacitinib for last 2 years. How should we go about this situation?
Yeah, if they are already on tofa, there's nothing that you can change, right? You don't recommend an abortion or termination of pregnancy. You hope for the best. If they are well controlled, I think that's more important than anything else. If the patient has got pregnant or conceived on tofa, you just continue with it.
We have to continue with tofa, or we should stop and assess non-invisively?
No, don't do that, because as I said, you're risking a flare, which is worse than continuing tofa.
So does the choice of biologic change during pregnancy?
No, it doesn't. All the biologics are equally good. You choose it depending on the merits of the patient's problem. Is it ulcerative colitis? Is it Crohn's? How much is the disease burden? How active is it?
So pregnancy does not determine which biologic you choose. You
No.
continue to treat as you treat
No,
normally.
absolutely. Anti-TNFs, maximum amount of experience with that, and the safety profile is good. So anti-TNF would obviously be the first for most of us.
Question to Dr. Agarwal, sir. We see a lot of patients who actually have functional abdominal pain. So how much do we investigate before labeling them as functional abdominal pain? I mean, when to stop investigating?
See, that is what I wanted to bring out. The amount of investigation which you normally start right from day one. You need a serial abdominal examinations to really say that the person doesn't have an organic disease, which I think out of experience in the OPD, after taking the history, you come to know very well whether it's a biliary one, a splenic one, a patient is cirrhotic, non-cirrhotic, from the history of food habits, from the history of alcohol habits and other things. If it is absolutely functional, the only thing which you normally see is that you start a patient, if you feel that he is not getting better on your counseling or on your minimal PPIs or an H2RAs, go for an endoscopy to find out. The commonest thing which we normally have is the functional dyspepsia, which they normally come up. If they are really not getting better, even with PPIs after endoscopy or an H. pylori treatment which comes out to be maybe falsely positive, then one should really think that the person is functional, and you should add to your PPIs and TCA or an SSRI and wait for the outcome to come maybe for 4 weeks or 8 weeks.
Would you advise things like capsule endoscopy or mesenteric angiography to categorize functional,
See,
differentiate?
until unless you have got any evidence of a person with an mesenteric ischemia or something, only one should go ahead to do a CT or an MRI, a venous visceral arterial phase study to see the washouts and other things, which normally at times on an endoscopy or any other procedure will not tell you. Even an ultrasound will not tell you exactly until unless the person really sees, that where the vessels are. If that is all ruled out, I don't feel that the capsule endoscopy has got any role until unless there is an evidence of it.
And so what is your preferred drug to treat functional abdominal pain? SSRI or TCA, and amongst them which?
I believe more on TCS.
Amitriptyline.
The tricyclic antidepressants at a lower dose to start with, not jumping onto the psychiatric dose of 25 milligrams twice a day or something like that. Even a 10 milligram dose is more than enough.
So the last question, and then we will
Is there, my question to Dr. Nandu, is there any additional benefit of using PCAB over PPI for post-EVL ulcers?
I think there is no trial of such. I have not.
There was a RCT on that.
Yeah, but that is for non-variceal. And they, after homeostasis, they have trialed the vonoprazole versus the PPI, and it is recently published in August. This ACG guideline, and they have shown with the forest classification 1A, 1B, and 2A, 2B. After endoscopic therapy, they use the vonoprazole versus PPI with the IV PPI versus vonoprazole 20 milligram per 1 month. And they have shown the 7.1% rebleed in the vonoprazole group, and with the PPI 10.2%. So it's not come in the guideline yet.
Actually, I was aware of an RCT which showed that there is a lesser ulcer risk and less ulcer size with PCAB versus PPI. But there was also data that PCAB, especially vonoprazan, has some liver toxicity. So both are dichotomatic reply.
Before it was shown liver hepatotoxicity, that's why it has not come. But with the vonoprazan, it has less side effect. I have shown the first that chart also. They have also shown it's non-inferior and non-superior and then non-inferior than that trial.
So we conclude this session. Thanks, moderators and chairpersons. So we will have a short tea break and we will reassemble at 11:30.